So welcome everybody. Today we're going to talk about how to implement quality assurance into your clinical studies. And all of us here on this call are involved with the ZIKAlliance project, and this is part of the big Zika program that's being run through the EU. And you're all working on this incredible study to look at pregnant women and follow them up during their pregnancies, following up the babies and then later the children. And the question we're addressing today is how can you all build in some research study monitoring or quality assurance into those into your studies so that you can make sure that the data is high quality and the studies being run as well as possible. So what we're going to talk through today is why we need to make sure that the data is high quality in clinical studies, and then how we can do this in this actual study that you're doing in your sites through the ZIKAlliance network. So we all need to know, obviously, that we run these studies to our protocol, and we're all running our studies to the same protocol so that everybody's answering the same question. And the way that we operate the study obviously is around ensuring that the rights of the participants are protected, but also that you're looking after not only your patients on this study, but every patient in the future whose care, treatment or management may well be changed because of the data that you've gained in this study. So everybody involved is really important, and everybody involved in the study needs to understand why their particular aspect of the study is really important. And they also need to understand how the study is running and why, so that they can think about where mistakes can be really, really impactful and make a difference to the outcome of the study. So one of the things we're going to talk about a lot today is how this study is running and where could errors happen, where could things go wrong, how can we spot them and how do we avoid them. And this is really all clinical trial monitoring is thinking about where things could come amiss and trying to prevent them. So what we're going to do is look at this study and see how we can think about what mistakes could happen, and then how we can plan to monitor the studies to check they're not happening and then mitigate them in happening further. But what I'm really hoping is that everything we talk about today for this study is just some tools and approaches that you can put into place for any clinical study. And so this is a case study really, and I think the things we're going to talk about and some of the ideas we'll come up with, you can apply to any clinical study at all, but we're going to use this study as an example. So what you're doing in this cohort study is trying to find out what the risk is of Zika virus causing these congenital abnormalities in babies, and then to find out what these abnormalities are and try and characterize them, because we know so little really about what's happening with Zika infection and the abnormalities it's causing in pregnancy. So we can easily think where inaccuracies to this data might happen. And it's about determining what could go wrong when you're taking these measurements from the mums and the babies. And these could be things that could go wrong about the accuracy of the data you're collecting, what happens to the samples, but also there's probably lots of issues around ethics and safety and making sure that consent is being given properly from the mums and making sure we keep them in the studies. So let's think about those errors and how we can set up some processes to mitigate them. What I usually do with study teams that I've worked with over the years is I've come up with an approach called the study walkthrough, and this works really nicely. And what I've done with these before is I get everybody involved in the study into a room, and we get lots of big pieces of paper and we sit down and we talk through a study walkthrough. And so this is where we work out what happens through the whole process of the study. So in this case, where are you first meeting the mums? Who's talking to them about the study? Who's then giving them the information? When is consent being taken? When are they beginning to do things that are part of the study that's different to standard of care? What's happening to the mums as they move from having given consent to taking samples? How are their samples being moved from the place where you've done the consent and taken the bloods? How do they get to the labs? What happens when those study samples get to the labs? How are those sample results then reported back to the clinic? Who passes on any data to the data management team? What happens during follow-up visits? What happens if the mums don't come back? Have you thought about flexibility? So it's really thinking about, you've got mum, and then you've got her samples, and then you've got her information. And just think through, and I often do this on 3 different pieces of paper, what happens to mum during the duration of the study? What happens to her samples? And what happens to the information you collect from them? So if you talk through all that in terms of the operational realities, this is really how you should be generating what your standard operating procedures are, so you can plan for everything that might happen. And then once you've got your operating procedures, then that's the point where you can think about, right, what's my quality management plan here, or monitoring plan, to make sure that I can spot any problems that might arise and do something about them. Now, I'm deliberately using the term quality management and monitoring because they're really the same thing. Clinical trial monitoring is a term that's used often in regulatory trials, but it's just quality management under a different name, and we can use both terms simultaneously. This is an observational study, and it's just as important that the data is accurate as any clinical trial, but it's often thought about in a bit more of a straightforward way than perhaps the high level of rigor that happens in regulatory trials. But actually, I think it's just as important that data is accurate and that the study is run really well. So we can talk about monitoring and data quality in exactly the same way. So now you've got your SOPs because you've done your study walkthrough and you know how the whole protocol is turned into operational procedures. So around your SOPs, you can now begin to write your quality management plan. Now, and this could also be called a monitoring plan, but it's I'm using quality management here because I like that term, because that's really what we're trying to do. And the whole idea of this plan is consider where things might go wrong and think about what you can do to stop them happening. So again, let's think about what's happening with these mothers as they're presenting for their first visit. You're taking a history, you're collecting their medical details, and you're taking these samples, bloods and urines and ultrasound if it's available. What happens to that data? Who's recording it? And where is it being written down in the first place? So you can see we're beginning to think about the process of writing down the data, transcribing it into data capture forms, and the samples being moved to other places, to the laboratory and however they're handled there. Some of you have also got some add-on studies or extra procedures that are being done with these studies, and obviously you need to think about these in the same way. What could happen about making sure you've really got consent for the extra samples, and thinking about how they're going to be handled properly, and making sure that there's nothing that can go wrong with looking after those samples, or making sure that they're tracked properly. So let's talk through what you might think about if you're writing a quality management plan for this study. What are the steps that are going to be going on in this study that present a risk, and what could go wrong? This is a nice, straightforward observational cohort study, but there are some really fundamental areas where there could be problems, and this could really impact the success of this study. And the whole idea here is that all of us are going to run these studies really well, so that the massively important question that's been set can be answered. So that means we need enough patients to be enrolled, we need them to come back for follow-up, and we need to make sure that all the samples are taken correctly and all the data is really accurate. So here we're going to drill down into the real steps that are important, that could, if they go wrong, they could jeopardize the ability of this study to answer its question. So the first thing that can happen is during consent and information given. What I always say here is there should be a very happy level of patients that say yes and patients that say no. When I go and visit study sites and I hear that 100% of mothers have said yes to these studies, that worries me a little bit. And equally, if you have perhaps more than 70 or 80% saying no, then there's also something going wrong here as well. We know this is a safe study. It's gone through ethics committees. It's a perfectly reasonable and valid study that mothers hopefully will understand the reasons for doing and be willing, in the most place, to say yes. It's always a good sign if some mums just say no, because it means you have explained to them that they have the option to say no and it's their right to do so. If you have too many saying no, then the consent form might be a bit misleading and people might be being frightened off. And so this is where we need to be wondering what's happened if you have too many people saying no to taking part in research. And equally, if too many people are saying yes, 100%, you do wonder if they really do understand that they do have the option not to take part. So there's things that you can do to make sure that that's in place, and we'll come back to that later. but community engagement and really working hard on your consent form and thinking about what the information is that you're giving is really the best way to adjust what's happening if things are going wrong with the process of taking consent, and making sure that staff are trained. So your quality management plan should have a whole section talking about how information is given, what information is given, and just keeping an eye on if you've got that really reassuring level of most patients saying yes, but some quite perfectly okay saying no. So the next step where things might go wrong is taking the history and later recording other patient details when they come back for their follow-up visits. So this is where you're probably writing things in patient records, and then you might be having that data transcribed into the case record forms. So you need to make sure it's accurately written down, and there's a really clear process between transcribing the data from the patient's notes into the case record forms, and making sure there's some checking for accuracy in that. The other thing that could go wrong in this step is the patients might be lost to follow-up, or they might, meaning they don't come back for their follow-up visits. Lost to follow-up is the single biggest thing that causes studies to fail, and it's very common. Now, one of the biggest things you can do to mitigate this is really make sure you talk to the mums and they understand what's being asked of them. And we'll come back to that in more detail later as well. The last thing that is a big area for this study where things could go wrong is the samples that are being taken and how they're handled and analysed, because the laboratory samples are a huge element of this work. So, firstly, it's really important that the patients understand what samples are being taken as part of their standard care and what is being done that's extra for the purposes of research. I've seen lots of situations where mothers have said no to studies because they think they're being asked to have more samples taken, when actually it's the same sample that they've used for their clinical care that's being used for research purposes. So nothing extra is being asked from the mother. But the consent form has actually been a bit confusing, and the person sometimes giving consent has confused the mother unnecessarily and suggested that made them believe that they're having all these extra samples taken, when in fact the same samples that were used for their clinical care are being used for research. Sometimes, of course, it's an extra volume that's being taken for research. And again, it's really important to make it sure it's clear in the information sheet what's being done as their normal routine care and what you're asking of them for research. This is a really common thing that happens, and it's really helpful to think about whether that's you've got that right with your patients and your information giving. So let's think about whether it's an extra volume of blood, new bloods, or new samples, and make sure they're clear about that. And then it's a case of how these are labelled, split out, aliquoted, sent to the laboratory and handled, making sure nothing can go wrong in that process, and how you're going to monitor it. And then once they're in the laboratory, making sure the analysis is done well, the machines are up to date, and everything's working as it needs to do in your operating procedures. And all of this is going to be thinking about where we can spot mistakes that might happen and how you can mitigate them. Lastly, you're going to have sample analysis results to get back to the clinician, put into the patient notes and the case record forms, and thinking about how any results are going to be reported back to the patient. Now, I'm sure you can all think of other things that I haven't said here, because I've not sat down with you all and walked through your study. But once you've done your study walkthrough, you'll probably come up with a longer list of this for things to think about. But this is just to give you some idea of how you can begin to think of what headings you might want in your quality management plan, of things to spot where problems might occur, and then how you might mitigate them. So, what mistakes could happen, and then what can you do to mitigate them? So this is really the detail in your quality management plan. So here is where we're going to think about writing down who's going to be checking these things and how often, and what could be done to change the situation if it is going wrong. So the consent question is really interesting, because this should begin long before your study starts. And this is why I like the phrase quality management, because quality management should be part of the whole process of your study, right from when the first question is considered. And it's not just doing monitoring visits once the study starts. So the information giving and consent process works really well if the community is engaged long before the study starts and you really begin to talk to them about what's going to happen. We've got some resources that can help with this on the mesh area of the Global Health Network, and we've given you the link here. So who is going to be giving the patients this information, and have you trained them, and how can you check? You could pop in and do spot checks and watch them give their consent. You could even talk to the mothers at later points. And obviously you can go over the consent form and check that it's compliant with the protocol and the standing operating procedures. And I really think this general idea of that some people are saying no and that the majority is saying yes is a really good rule of thumb to know that people do understand they can say no, and that it is okay if people do say no to a study, but you really shouldn't have more than sort of 70 or 80% of people should be saying yes. And if it's more than that, then you're worrying them unnecessarily with your consent form, because we know it's a safe, straightforward study. So you need to see consistency in the message, and you need to make sure that the right information is being communicated. Now, the other thing that's really important that links in with whether you run the risk of losing patients at follow-up. So you get them for the first visit, but then you never see them again. And this can often be something that's cropped up during consent and information giving. And also for this study, one of the big problems may arise when you get to the babies being delivered and wanting to make sure that they still consent for their babies to have samples taken. Now here I strongly suggest an ongoing consent program is used. And whether or not you've got this built into the study now, it's something you should think about with your patients, that at every visit you reassure them, talk to them, explain what's expected and what's expected and what's going to happen when they come back for their subsequent visits. Again, reminding them what would happen anyway and what's happening that's part of research, and that most times it's exactly the same, and just perhaps an extra volume of blood or some extra samples that might be taken for research, especially in these centres where you've got local extra studies happening. If you talk to the mums and remind them what's going to happen, keep reassuring them, keep discussing it, then it won't be a surprise when they come for their visits, and it should be possible to really make sure they stay involved in your research and you don't lose them to follow up. Now, recording their medical information in these follow-up visits. With this question of follow-up visits, have you set a window around which you can think about if they're a few days late, does it matter? Because that's really helpful in when you get to your database level. And how are you going to follow them up? Do you have phone numbers? Do you know where they live? And can you trace them? And what is your process for doing this? And what level of missed visits is a problem or not? This all needs capturing in your quality management system and part of your something that you can keep checking and measuring. Now, when the patient's medical information is recorded, is it written in the notes and then transcribed into case record forms? Or is it being put straight into your tablets and that they become the source data? So source data is what we call the original information, and it's what we always check against. So source data is things like your clinic logs or clinic diaries, where it will list in the patients that come in that day. And that's a really helpful document to check against for enrolment, for example. How many mothers came in that morning? How many were approached for consent? And then how many said yes or no? And it's this sort of original documentation that's really important to check against what's entered into the data capture forms. What you need to do is decide what volume you're going to check and how burdensome that is. It is usually a good idea at the beginning of the study to check a lot, and then if it's all okay, you can taper this down. So who is transcribing from the source data and into the data capture forms? What volume do you want to check, and how often are you going to check it, and who's going to do that? This is what you need to think about in your quality management plan. So the sampling is perhaps the biggest area where errors might creep in and mistakes can happen. And the first thing that might happen is mothers might refuse to give samples. And again, I really emphasize this matter of making sure the mums understand what will be taken anyway for routine care that they need to understand how they are and how their baby is, and that what's being taken as extra for research, because it's been true that sometimes mothers have been in research studies and they've refused to have any samples taken, and it's actually been a fact then that they've had samples missed that they needed for their routine care because they thought it was all for research. So it's really important to explain that difference and reassure them. So the processes that happen now of labelling, transporting, moving the samples around, thinking about where they're travelling through to and what the windows are to make sure there's not samples left in hot or damp places, or that they're sat in the back of trucks for too long. How can you check this? What's the recording in and out? Where is this being tracked, and how can it be checked? This should be thought about too. Where can things go wrong? How can you record so they won't go, so we know if they've gone wrong or not? And then how can this be checked? And again, you might not need to check at 100% of every single record every single time, but a reasonable number so you can get the reassurance that everything's working well. And this may need to change over the duration of the study. Now, in the laboratory, there's lots of other things that need to be checked too. Obviously, everybody doing the assays needs to be trained on those particular assays and the operating procedures for delivering those. Machines need to be calibrated and validated, and fridges and freezers need to be monitored for temperature. Is there backup power? Is there a training record for the staff? Somebody, probably in a lab, could be in charge of managing their own quality, and that's a really nice process to add on to somebody's job role. But how often are these checks happening, and who's going to be doing it? It could also be your normal study monitor or your quality manager, but somebody needs to have responsibility for this. Once the results are recorded, who's checking these results against the source data, and are they going to check all of them or just some? And then how are they transcribed into the data capture form, and how can this be checked? So these are the main things that you need to be looking out for in this study. But as I said at the beginning, these aren't particularly different from any study. And it's usually this, if you think back to the study walkthrough I talked about earlier, it's this thinking about patients coming into a study, being given information, having their medical histories recorded, their medical data recorded in follow-up visits, and then they have samples taken. And so you've got these two streams of activities really. You've got the patient coming in for their visits, and then the patient's samples can be considered on one stream and then their data on another. And all the time you need to be thinking about how that matches up with the protocol and what could be put in place to make sure that mistakes aren't going to happen. So now you can all sit down and write fantastic quality management plans if you haven't got them already. So I'm just going to give you some of my top tips from running lots of studies all over the place, and think about things you can just put in place to run good studies, but also some things that can be described in your plans. Who is working on your study? A role and responsibility log is a really, really, really useful piece of paper. Set up a table that gives everybody's name, what roles they've got in this study, and then who else those roles could be delegated to, and briefly what that role is. And then when the people whoever it is who's tasked with quality assuring your study can have a look at who's doing what, they know who to talk to, and it really helps make sure that everybody's been trained and understands each other's role as well. Regular study team meetings are absolutely essential. The great starting point is this study walkthrough, but you really should be getting everybody together at whatever time point you think would work best for you all. Maybe not every week, but probably every month, and going through what's happening in the study. How is recruitment going? Are people agreeing to take part? Is there a problem of getting mothers to agree to take part in the study? Are there any problems with sampling? Is the lab needing any more information? So there's lots of things that can come up in study team minutes, and you can use your walkthrough and the steps and processes along that as almost an agenda for these meetings to make sure everything's going really well. And it really helps that every single member of a study team really understands everybody else's role and also what problems are happening. It's really great to have the lab team talking to the clinical team, talking to pharmacists when you've got those involved, talking to the community-based workers if that happens, and so that everybody really is understanding of their own roles, but everybody else's. So who is going to do this actual checking or monitoring? It doesn't have to be external in any way. You could simply appoint one of your team to be your quality manager person, or you might have an external monitor that comes in. And it could be both of these things, but it should be written in your quality management plan who it is and how often they will be visiting or what their role will entail. So now you should decide actually what needs to be checked. So thinking back over what we've just talked about, this will be around checking consent, how that has happened, how many patients are being recruited, is that on track, is the information being given properly according to the SOP, what's happening with transcribing the information across, how the sample tracking is happening. Keep thinking about what mistakes matter, and that will guide what to check. At the beginning of a study, it's probably worth checking everything at 100%. So maybe for the first 10 patients, 5 patients, 100 patients, depending if it's a really massive study, but pick the appropriate number of patients that would be worth doing 100% checking at the beginning. And then when you're confident that everything's running well, you can drop that back to maybe 20 or 5% if necessary. And this is the same for doing checks from the patient notes or source data, such as laboratory reports, into the case record form or data capture system. It's probably worth doing 100% check at the beginning for the first few patients to make sure there's no glitches. But as the study progresses and you become more comfortable, it's probably okay not to check everything. And it's really the most important pieces of key data you may want to keep doing 100% checks with. But this is what you need to talk about with your study coordinator and decide what's an appropriate level of checking. So, how many consent forms will you check, and what else might you do? This will tell you really how well recruitment's going and making sure you've got the correct information that you need on those actual consent forms. But it's more than just checking consent forms, isn't it? You really need to think about whether this is started right back at the start with community engagement and whether you are getting enough patients in or if you're having too many refuse. So the loss to follow-up question, this is the really major thing that can happen in most studies. So if you do have a significant rate of mums not coming back for follow-up visits, what will you do and how will you spot it? How early will you spot it? And then what will you do to mitigate that? Can you work with the communities? Do you know where they are? Who will have a responsibility for this? The other thing that is quite possible to happen in the studies is that mothers might withdraw consent at birth or if the pregnancy ends at an earlier point than birth. So this will be very difficult to mitigate at the time, and I strongly advise that as much as put in place as possible before these events to try and prevent this happening, which will all be around community engagement and explaining the study really carefully. But this does need tracking very carefully and some study meetings to think about what can be done if it is happening. Samples get lost and samples get damaged, but this wants to be minimised as much as possible. And if this can be done, then how can this be mitigated most effectively? When we've had samples moving across Africa quite regularly, we've had to be really careful if it's the rainy season and the dry season and what happens to the roads. And we had to change from using cars to using motorbikes, for example, because some of our roads got blocked and the samples were becoming damaged before they got back to the laboratory from the clinic in the field. So think about the route that the samples are taking and what might happen if there's a delay or something happens. So again, it's will there be forms to check samples out and check them in, and will they have times on them? How can you know that things could go wrong, and then how can you prevent it? This study could have highly varied data being collected and information, and this could be quite problematic for getting data into the database. So this is where you are going to need a data management plan and later a data analysis plan. And this is the overlap between a data management plan and a quality management plan. Ideally, you'll have had some agreed format for describing outcomes or units or descriptions. And you might need to go back and think about those again, especially for the sites where you're doing extra activities such as ultrasound, or maybe some of the swabs or some other questions you're asking the mothers. How are you going to capture this data and what format is it going to be in? And if possible, talk to other sites so that you can agree a similar format. Because this is the biggest problem later on, is trying to come up with standard terms to understand what's happening with these patients. Staff capacity and variations in teams are a real problem for most studies. And so what we need to think about here are how new members into the team will be trained and how they'll be looked after and supported in the studies. And how, when you do your quality management or monitoring studies, will you make sure that they understand the SOPs that they're working to them. Again, team meetings are brilliant for this because everybody involved can come along. Another big challenge to studies like this are the wide variety of sites. Look at the wonderful variety of countries we're talking to now, and the great distance between different sites and also the sponsors and study coordinators. How will there be any communication between you all? Will you share what you're going to do here with your quality management plans? I think that would be a fantastic idea and help all of you. What can be done to try and make communication as easy as possible? And I'm sure you can all think of things, and you can add this in to maybe not even your quality management plan, but just part of how you operate your studies. It can also be a huge problem just within sites to make sure you've got that communication, because this might be really important when you've got different teams working on studies. There are often staff that are employed by the studies and then staff that are employed by the hospital or clinic. And that can cause really quite difficult sort of organisational political problems when you're running clinical trials and clinical research studies like this. And again, team meetings, making sure everybody understands their role, how it will happen, how the study will actually happen in a caregiving centre, and making sure that everybody else that's on the ward or in the clinic is really, or in the laboratory, really understands what's going on so that they're sympathetic and supportive even if they're not involved. So who is going to be the lucky person responsible for assuring quality of your study? Your in-house quality manager is absolutely fine. That works really well because they understand the study and they're part of the team. It might be that you have an external monitor appointed, and that is obviously truly excellent, and they'll come in and they'll help you. And a monitor should be, again, seen as part of the team and not like a policeman that's coming in, but somebody that is sympathetic, supportive, coaching and helping. And it would also still be good to have an in-house quality management person nominated, because then you've got somebody who's day-to-day involved with looking after the quality of the study and thinking about really who can understand it from your perspective, and then they can work really well with the external monitor if they come in. Reciprocal monitoring might work really well for this study, and I know some of you are already involved in this, and we're going to talk about this more in a minute. And this is something that can still happen alongside a local quality manager, or it might be your own quality manager that becomes a part of a reciprocal monitoring scheme and goes elsewhere to look at somebody else's site. So whoever's doing this, you need to think about how many visits do they need to do. Can they do database level checks as well? And what would this mean to the data management plan? What frequencies are these visits needing, and how will they write up these visits, and how will they report it back? And these are all elements that will go into your quality management plan and help this be rolled out in your site. Reciprocal monitoring is really easy and it's very low cost. It works quite well if it is feasible for people to travel in between sites, because it shares best practice between different sites, especially if they're involved in the same study. It really helps, and it's really great for people to meet each other and talk about the problems they've got. But it could also be implemented within a single hospital or research centre, or it could be done like this in between countries, but you've obviously got the added travel cost. But it's a really nice way to build relationships and building continuous improvement, because people learn from each other and what they do. So if you do want to do the reciprocal monitoring scheme, we've got a whole heap of materials that you can use on the REDe network to find out how to do this. You need to nominate people to the scheme. You need to find your own monitors and train them, and there's lots of resources available for this. And then you need to set up your scheme with the other people that are taking part in it with you. Agrees monitoring plans, schedules, and how they're going to be set up across the sites. That's a very rapid overview for reciprocal monitoring, but there's lots more information on the platform. So I'm going to finish here because I want to give you all time to ask some questions, but I hope we've gone over how data quality is such an essential element of conducting good research, and everybody's responsible for it. It really doesn't need to be daunting, time-consuming, or expensive, and should be part of the whole process, right from setting the question to finalising the report. You can think about the areas that matter, and that's what you need to focus on. You don't need to necessarily focus on every single element of that's being written down. Things like signatures and dates are important, but it may not matter what ink they're written in or what format. What does matter is that any mistakes that could influence the answer of the study or the safety and the well-being of the patients. Your staff can be trained as monitors, and this is great for career development and will raise the research standards within your site. On the REDe website, we've got a whole toolkit for this, and you can use this to help you write your quality management plan. And it also is where we introduce the reciprocal monitoring scheme or explain in-house monitoring, and you can decide what's more appropriate for your team if you haven't put anything in place as yet. Also, on the Global Health Network, there are a range of courses that might be helpful for you in thinking about this study and any wider training you'd like around running clinical research. Lastly, we're talking to you from the REDe team, and we've been funded by the EU to support these Zika trials, but actually it's really about leaving lasting research capacity for any type of clinical study beyond these Zika, really important Zika cohort studies. So we hope that all this discussion we've had about quality management you can apply to this studies, but others in the future. But there's also heaps and heaps of other resources and information on the platform. And this has been set up for you, and we really hope you get involved. And what will be fantastic is for you to jump on the platform and report back what you think about this course today, and if you'd like any more like this, or us to do a follow-on one to talk about perhaps monitoring training or the wider areas. Thank you very much, everybody, for taking part this afternoon, and please stay in touch with us online, and very, very good luck with your incredible studies that you're running at your sites.